Well, thank you very much for inviting me, and I must thank Faiz, Renato, Ninke, and Tessa, and all the team of here on Leiden. And now I am coming to the basics after the impressive talk of Tobias. But the application in gynecological cancer, that is one of our topics in our hospital. However, I am warned with this approach of semi-robotic, as Renato told before. But concerning the topic, you all know that the gynecologic malignancies involve all these structures, and as been told before, 95% of the procedures are involved in lymphatic mapping and sentinel node procedure, and the drainage is well known, especially in vulva and vagina, and it's a little bit more complex in pelvis and abdomen from the other parts of gynecological structures. And we rely on the very basic approach in visual and acoustic devices, and the images provided by preoperative lymphoscintigraphy as well as blue dye for the ancient times. And you all know that there are a lot of radio tracer, or not only radio tracer, to provide the lymphatic mapping, and we can use a lot of them. However, getting into the topic, that we will need is to avoid these kind of things. That is normally one of the approaches of the vulvar cancer in order to get less morbidity in these cases, and this was the developing of the sentinel node procedure that was started with the injection of blue dyes, as you can see. However, the blue dyes only had a detection rate not quite good, below 90% of cases, and this is why the radio tracer come into the field and get an improvement of this detection rate. And of course, if you have an image, a preoperative image, you can see that it works very well. At least in our experience, we can detect the sentinel nodes in 97% of cases. And after that, in the intraoperative room, you can add the blue dyes as well. And with the aid of the probe and the preoperative knowing of the lymphatic mapping, then it's quite easy to retrieve these sentinel nodes. Summarizing this basic procedure, the detection rate in overall in more than 40 studies, it was fairly 95%, with a false negative rate that is very important, specifically in vulvar cancer, of about an average of 8%. But concerning the tracers, if you use only blue dye, the overall detection rate is about 63%, and this is why the combination technique goes pretty well with a detection rate of 87%. If we apply this to cervical cancer, it is not quite difficult to inject the radio tracer in the cervical cancer, but the important thing is that you can mapping both pelvic sides. It's very important for this type of cancer. And then if you perform pretty nice lymphoscintigraphies, you can see thorough lymphatic mapping and different aspects of the external iliac or common iliac, as well in parametrial nodes. However, we lack the anatomical background in this kind of images. However, it makes sense to perform a lymphoscintigraphy previously in order to give the gynecologist an overview of what we will have on the operating room. But it's important not only for the visualization, but also because the lymphatic mapping detects nearly 35% of drainage in unexpected areas of the potential lymphadenectomy. But then, in these particular cases, we have to adapt our conventional probes to laparoscopic probes. And then this was a challenge for us. In order, we have to master the use of laparoscopic probes and, of course, to get in other options. And this is our schedule, preoperative schedule, in order to get powerful to go to the operating room. And this is called our probe wars in nuclear medicine department in Barcelona. We are a little bit freaky, but could be. However, in the operating room, we use blue dye because it is demonstrated that the combination of the techniques are more convenient for this type of procedure. And as you can see here, with the combination of the audio signal and the blue dye in this case, you can imagine that this kind of patients are normally younger and thinner than endometrial cancer patients. And this is very nice for this kind of approach by combining the blue dye and laparoscopic probe, as you can see in this short video. Okay. And this is demonstrated in the body of literature with the detection rate is better with the combination of the both techniques. However, if we perform in endometrial cancer, there is a controversy now not only in the indications to perform lymphadenectomy and sentinel node procedure, but also in the way of administration of the tracer. It was started many years ago with intraoperative blue dye injection, as you can see here. This is the very primary study that was published in 1996. And we perform it intraoperatively by injecting laparoscopically. But the problem is we lack of image at this moment. And normally, the patients are totally different from the cervical cancer patients. And the situation is this one. And you can see nothing stained blue because there is a large fatty tissue surrounding the vessels. And the other problem is there is no consensus on what is the best injection site for perform the lymphatic mapping in endometrial cancer, and has been described a lot of injections, and with different detection rates, as you can see. But one of the things that we are aware is that if you inject in the cervical injection, it's very convenient and probably the easiest one. There is a low percentage of para-aortic drainage to the sentinel nodes. However, if you inject deeply in myometrium or subserosa, then the increase of this percentage of para-aortical drainage. This is why our team of gynecologists in our hospital developed a novel way to inject that consists in injection of myometrium guided by transvaginal ultrasonography. This is a little bit tricky to perform. However, the detection rate is not quite bad. It's about 88% of cases. However, we keep in mind that the robotics in this application must be demanded by our surgeons, and the system goes well with the combination of blue dye and laparoscopic probe as well. At last, for vaginal and ovarian cancer, there is a scarcity of data, but however, there is a recent publication of a Maastricht group here in the Netherlands about the potential lymphatic mapping of ovarian cancer, that it could be the next step in gynecology to perform. But taking into mind this background, the classical background, then we have some drawbacks to solve in order to give a more comprehensive and refine the technique as well. This is why, as Professor Valdez almost told before, we have 8 for nuclear medicine people, the use of SPECT-CT, particularly in these kind of lesions, as well the intraoperative imaging, and finally, with the group of Thijs van Leeuwen, the fluorescence imaging. All of you know the advantages to perform the SPECT-CT because they provide us a better anatomical localization and so on. And there is now a lot of data concerning gynecological malignancies to perform the SPECT-CT. However, in the current guidelines for gynecological cancer for the European Association of Nuclear Medicine, the SPECT-CT is not widely used because the deep drainage is less frequent than the other tumors in this area. But you can see on some posters on the exhibition area, and one of them, there was a study from Dr. Colarino that was involved in Netherlands Cancer Institute last month in order to perform a SPECT-CT in vulvar cancer, and then they demonstrated that nearly more than 80% of cases the drainage is in the inner part of the inguinal road, and this could be convenient for the surgery. But the situation is, on the contrary, mandatory to perform SPECT-CT in cervical and endometrial cancer because it provides a better contrast and spatial resolution and provides us a very information in very complex drainage, like could be in parametrial sentinel lymph nodes, where the gamma probe has problems to identify, and in other unusual locations. And it has been nicely demonstrated that not only it's good to perform, but has a significantly reduces the intraoperative sentinel node retrieval when perform this kind of surgery with robot assistance. In our institution, we perform routinely this SPECT-CT, and then we demonstrated that it solves us some particular problems, as you can see. And the same situation is in the endometrium cancer, when you have more than we want this kind of image, because the spillage of the tracer into the peritoneum, and then by performing the SPECT-CT we can identify, not always, but in some situations, the sentinel nodes. And this was demonstrated by my colleague Andres Pericinotti that worked with us until 2013. But concerning the intraoperative imaging, we can adopt the use of portable gamma cameras. These are special designed gamma cameras with a reduced field of view, but allow us to gain an activity distribution of the surgical field, and most importantly, in real time. And it permits us the continuous monitoring of all procedure. And this is, for example, in vulvar cancer, the portable gamma camera provides us a continuous monitoring of their sentinel node retrieval, as you can see in these 4 slices. We normally use this kind of portable gamma camera that we have in our institution, but we faced on the possibility to perform it by continuing monitoring the laparoscopic procedure, and it was a challenge for us. But we take profit from our colleagues from the Netherlands Cancer Institute with providing the background that it was in urology with Hen, Oscar Brouwer, and Valdez, almost. They described a technique by adding an iodine sheet at the tip of the probe. And then we adapt to gynecological procedure, and as you can see in this case, with a bilateral drainage, this is the image provided by the gamma camera, and this is the real situation, and this is our approach, a very Catalonian style approach, because in order to save money. But we put at the tip of the probe and mark the situation, because the gynecologist knows where the seat is. And then by placing the portable gamma camera at the top of the abdomen, we can monitoring all the procedure continuously. But the key point is that iodine sheet displays this signal in green circle that matches with the signal provided by the Sentinel node with the ignition. And then when they matches, and this is the real situation, and you know that you are in the correct aspect. And of course, in this case, were good because it was stained blue as well. But there are other potential applications. If you miss the seat on the floor, like in my case, there is a potential application of the gamma camera in order to solve this problem. Because, okay, but not only for searching the seats that I left on the floor, but also in the difficult to locate Sentinel nodes, they provide us some support, and it was published in this situation. And our colleagues from the Netherlands Cancer Institute apply it in 15 cases of vulvar carcinoma, and they showed that the gamma camera found the 10 additional Sentinel nodes in these approaches. Then we use the intraoperative approach with portable gamma camera because we provide the dual isotope imaging and the control of post-excision Sentinel nodes. And of course, there is a very important thing, the detecting Sentinel nodes near the highly radioactive background, and for searching other things that will this. But now we are testing the addition of an optical component to this portable gamma camera, and with my colleague Dan Hellingman in the Netherlands Cancer Institute. And this looks like in this approach with the normal gamma camera slide, and more or less they depict a very convenient and friendly anatomical background in order to give this information to the surgeon. But other potential applications that, as Dr. Renato Valdez told before, is to go to the mixed reality environment. And this is provided by the tracking system for the Eclipse that Tobias showed us before. And you can navigate after the scan of the area in order to get not only the image of the Sentinel node, but also, very important, the depth of the distance at the tip of the probe that this node. But the challenge, again, in gynecological as well as urological cancer is to apply it in laparoscopic approach. And this is the procedure during cervical cancer. Is similar, but the only thing is that the probe is angled in 45 degrees, and then you have to get a thorough scan of the vessels in order to give the more data and more precise data. But the other thing is to play with this kind of data that provide us with the SPECT-CT, and this is that Renato told us that you can apply these kind of things in order to put into the operating room scenario. And this operating room scenario looks like here, as you can see, that displays and then you can navigate with the tracking system and to locate the Sentinel node. But other possibility that is now developing is to perform a tracking of a handheld gamma camera. And these data are provided by our colleagues from Leiden in Pornick and Van de Berg. And this is the situation. It's the same like a gamma probe. However, probably the sensitivity and the precise location of the node is better, as you can see here in this one. And also with all this data, you can navigate either with the gamma camera, and either with the gamma probe, as you can see in this video. Okay. But finally, there is time for fluorescence. We are in the home of fluorescence here. And fluorescence, all of you know how it works, and there is a lot of devices to get the fluorescence coming into the operating room. However, we started with the injection of fluorescence or fluorophores without any radiotracer, and there is good approach, not only for open surgery, but also by laparoscopic and robotic-assisted laparoscopy. And there is a lot of data about the implementation of this kind of fluorescence tracers. However, this topic will be thoroughly described tomorrow by Professor Alexander Vermeyer. I hope I spelled it properly. And then we talk about with the combination as a nuclear medicine physician with the functional radiotracers that provide us the particularity that the phagocytosis of the macrophages can phagocyte the fluorescence item as well. And then by aiding the fluorescence to the normal radiotracer, we get a hybrid tracer with radioactive and fluorescent signatures. Then it was tested in 15 patients in vulvar carcinoma here in Leiden and Amsterdam. And after the preoperative aspect of that it was very successful, this is how it works in the surgical room. As you can see, the intraoperative imaging is performed by the application of the portable gamma camera in routine use with injection site and the Sentinel node very clearly defined. And in this case, we use a Hamamatsu PDE photodynamic eye that gives us this overview, this clearly overview, but we must dim the lights in order to give these nice images. There are other systems that provide multispectral images that cannot dim the light. But with this approach, that it's not different from the very routinely one, you can see a very defined Sentinel nodes. Then there is a high sensitivity of fluorescence-based Sentinel node identification, as you can see in these videos. And the results were quite good, as with the intraoperative detection of 96% and ex vivo fluorescence in 100% of cases. This put into the laparoscopic approach. We made 8 cases in Barcelona with this hybrid tracer, and the first 4, there was no good because we have this blue phantom, like I don't know how it works, but it was not defined. And we concerned about our problems, and then after a hands-on session here in Amsterdam in past November with Henk and Nienke van der Poel and contact with FACE, we tried to adjust some items, and we adjusted to upgrade our systems and optimizing the dose that we inject, because it's different from the urologist part of this procedure from the gynecologist. Then this is our schedule, how to label for hybrid tracer depending on which pathology we must get. And with this, this is very thing 10 years before coming here. This is our case, one of the cases, and tomorrow we will find another one. And after injection the label the day before surgery, and we tracking with the Eclipse system in this case. I skipped some parts of this, but the reality was that after the injection, we detect with the probe the auditive signal, but we don't see nothing clear, and we upset again because we miss the correct dose. However, after a nice dissection of the tissue, the fluorescence comes to the scenario, and then we were all happy in order because we can see not only the nodes but also the precise structure surrounding the nodes. And then our gynecologists were happy to the gain that we improved after introduce these kind of improvements. You can see. Of course, this could be applied for robotic-assisted laparoscopy. I am not involved at this moment on that. And finally, only one word about the new potential devices like optonuclear probe that not only reads the radioactivity, but also trying to read in acoustic signal the fluorescence part of the hybrid tracer. And then this is a topic for next generation trials. And finally, we don't miss the suggestion that coming from the USA, we performed some cases of radioguided surgery with the PET probe, especially for ovarian recurrences. In trying to get the suspicious lesions on PET-CT that must be biopsied, and they are difficult to locate on normal or surgical exploration. And it was based on this approach from Ohio State many years ago. However, in our schedule, with the PET probe, we always perform with laparotomy, that it is not the current daily basis. And there is what not succeed with our positron probe. And we try to perform another approach in order, if we get the PET-CT scan, then we can see where the lesion is, and we can label it with a drop of macroaggregates with technetium. And then with laparoscopy, you can go directly through this kind of lesion. And it was succeed very well. Then, for concluding, the Sentinel node is increasing use in gynecological malignancies, and the lymphatic mapping using the combination of techniques is the cornerstone of these techniques since early days. But although this is succeeded in more than 95% of this kind of tumors, we must refine the technique with adding the SPECT-CT and the intraoperative real-time images. However, the intraoperative navigation and hybrid fluorescent tracers can solve the remaining problems that we have. And finally, the PET tracer radioguidance is a promising tool for concrete indications. And I would like to conclude to give my personal thanks to all the group of here, the Netherlands, in Amsterdam and Leiden, for providing me more acknowledgement of these things, and we persevere and we go straight ahead, but we have always stumbles on the road, but we are always on the same direction. Thank you very much.